Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Join us in fostering a strong, supportive community where unity among surgical assistants is celebrated and encouraged. I'm John.
Hey, I'm Kelly.
Welcome, Kelly.
Yeah, how are you doing today, John?
I'm pretty good. And yourself?
Good, good. We're doing good. Today is a interesting topic. We're going to be talking about the team dynamics in the operating room, so the comprehensive operating room team and where the first assistant fits in. And we talked earlier about how that boils down to team dynamics in the operating room, which can be rewarding and challenging at the same time. So we're going to be talking about some of those discussion points today. First and foremost, I think we're going to start off talking about the core staff typically in the operating room. Do you want to start off giving us an idea of where that starts?
Sure. Typically, for every surgery, whether it's a general anesthetic or a local anesthetic in the operating room, in a hospital or in surgery centers, the team is pretty much going to remain the same. You're going to have an anesthesia provider, you're going to have a circulating nurse, a scrub tech, and usually a surgical first assistant. Not every surgery needs a surgical first assistant, but the bigger, more complex ones do. And it's becoming more of a norm to use surgical first assistants in a lot more surgeries now. So, uh,
It is. And I've actually worked in hospitals where a first assistant was staffed in every room, regardless of if they were needed intraoperatively in the procedure or not.
mhm.
So that in and of itself is interesting, is going to lend itself to this discussion today.
Yeah, you're right. I think more so when your assignments are given out during the day, usually a first assistant is assigned to a room. That's usually a surgeon that has however many cases, and you may not be needed for every case, but you are assigned to that room. And I do the same.
Right.
I try and stick around and help out as much as I can if they need me. If they don't need me, I
Right.
keep in constant communication with the circulating nurse. Hey, I'll hang out and help you if you need it. If not, I'm going to go take a quick break or whatever, or get the stuff ready
Right.
for the next case because I know the next case is a big case.
Right, but they're typically, like, cases like cystos, like
Hmm.
cystoscopies. I mean, typically, there's not a first assistant staffed in those rooms. Have you had the experience where they are?
Yes, I
You
traveled to
have?
a
I
few
mean, I've worked in one
hospitals
facility.
where
Mhm.
they've always
Oh
assigned a first assistant, and on call too, they'd call me in for a cysto when a
oh,
surgical first
really?
assistant isn't needed for a cysto. But in the middle of the night, it's nice to have an extra pair of hands should something go wrong, or you have a combative patient, or it's a big
Correct.
patient, and you know as well as I do, surgeries can change. It can start out as one thing, and then
Absolutely.
there's an issue, and we have to move on to something else. So yeah,
Yeah, that's true, and that's a good point. That's a good point too, because I know a lot of us first assistants will roll our eyes at
yeah,
having to be staffed in a cysto
true.
case, right?
That's
But,
true.
the argument on the other side of that is a extra pair of hands never hurts, and you
Right.
don't ever know what's gonna transition, you just don't.
Hmm.
I've only worked at one facility that staffed staffed first assistants in the cysto room, and at the time, I didn't like it. I didn't like that I wasn't doing anything intraoperatively,
Hmm.
but in hindsight, I learned a lot in those cases.
Okay.
I did in that particular facility, I learned how to run the laser.
Hmm.
Um And I appreciated then what the RN circulator was having to do, keeping up with fluids
Hmm.
hanging, and so I was able to really lend them a hand while they could document and chart. At the end of the day, it enriched my experience and my practice, so, I mean, I can't argue with it. Now, do I wanna do that all the time? No, I don't. That's just me personally, but so anyway, I think it
Yeah.
might be becoming more common, though, that we expect that facilities will staff first assistants in those rooms.
Hmm.
Podiatry is another specialty that first assistants aren't often staffed in those rooms,
Right.
but it's becoming, I feel like, more common, and there are some podiatry cases that it's necessary to have the surgeon does need that extra set of hands in there. Just talking about that, yeah.
I think it depends on the facility too. Some places have podiatry residents. So I was at a
Uh-huh.
a facility just before this one where they had podiatry residents, so they didn't need us. But
Mhm.
now where I am now, they don't. So I worked Friday. I did podiatry cases all day, but they were bigger foot and ankle cases because this doctor was foot and ankle fellowship trained. So they were
Right.
much bigger cases, like total
Right.
ankles, like MTP fusions, Haglund's deformities for Achilles tendons. and things like that. So
Uh-huh.
they were a little bit not your standard bunion or hammer toe cases. We
Right.
can still be just as helpful in those cases.
Absolutely, yeah, and I've learned a lot again in those. I mean, those aren't
Mhm.
cases that I was super familiar with when I was first starting my career and still not to this day. I mean, I wouldn't consider myself an expert. I'm much more
Mhm.
experienced than I was in the past, but it's amazing to me the complex cases that podiatrists
Oh, yeah.
are tasked with doing
Mhm.
sometime. The foot and ankle is no joke. We know
Right.
you know, it's easy to say, "Oh, it's just an IND," or "It's just a second toe amputation," but they can be complex cases and
Sure.
absolutely need a first assistant.
Yep.
So, and in those times, I've been really thankful to get in there and learn what I've learned.
I
So,
think, it's
good point.
dependent on each state. I think in the state of Florida, the podiatrists are responsible for everything below the knee. So that can mean ankle
Uh-huh.
fractures, some do tibial
Oh.
rottings, some do Charcot deformities, so there's a lot of different things, but you're
Mhm.
right, I agree, and I always take the
Yep.
opportunity to learn whatever I can, so I love to ask a lot of questions. Even if it's a
Right.
case that's maybe not that technically challenging, I always ask more questions so I can learn, maybe
R
know more for the next case or
Yeah, I do too, and I would much rather be in a case like that
Mhm.
than not busy at all. I can't stand to not be busy, so
Right.
I would, much rather go in a even a cysto
Mhm. I
than not
agree.
have anything to do.
Oh, yeah,
So I'm
exactly.
always looking for something to do. That's just the way I am. I don't like to be not busy. But going back to the core
Mhm.
staffing in the operating room, so we do have the anesthesia provider
Mhm. Right.
at kind of the apex. I kind of put anesthesia at the apex of the staff in the room. Anesthesia can make or break the case, right?
Oh,
I
yeah.
know I learned in my program that the anesthesiologist has absolute authority in canceling a case,
Mhm.
uh, if they see fit, depending on the patient status. It doesn't happen in some facilities where they're not seen in that light or not treated as such, but in my mind, at least, I do place them at the apex. So they're responsible for the patient and the surgery, whether the surgery goes forward ultimately. Um, in the anesthesia provider role, you could have an anesthesiologist, which is the doctor. You could have a CRNA, which is very common, the nurse anesthetist, and also anesthesia assistants, which are anesthesia providers that it's just like a CRNA, they just
Mhm.
weren't an RN first, right? So they're trained to provide anesthesia for the patient. I'm gonna talk about the circulator,
Mhm.
which is always an RN, and then I'm gonna let you talk
Mhm.
about the, scrub, and we're gonna then get into the FA portion, which is gonna be the meat and potatoes of this talk. But the circulator of the room is always an RN, always, always. They're a registered nurse. The circulator, I know in the past and even currently is kind of known as the manager of the room. They
Mhm.
kind of oversee everything. Um, they do so much, the circulator, they have to know the patient, the medical history. They go and check the consents,
Mhm.
make sure that all of the charting and the legal documentation is in order. First and foremost, that's their responsibility to make sure that chart is in order. All consents have been signed. We'll talk about this later when it comes to the first assistant. Obviously, that's something that I check and back up also. Everybody in the room really has the ability and the right, responsibility to do that.
Mhm.
Ultimately, it lands on I think the anesthesia provider for they have a separate consent, but the circulator's checking all those things, just making sure that, if we anticipate needing any blood products or anything like that, they've got that lined up. Once we get in the room and the surgery starts, the circulator is charting, documenting the case, specific times that we start doing things and end things in the case, and uh, doing the counts with the scrub tech. Anything and everything that needs to be documented, that circulator is on it. And then also they're the person that unfortunately has to run and get our things for us when we are missing things or need more things during the surgery. They're kind of having to make sure that we get those and they're expedited to the room. So they are kind of the go-to person, the circulator is. They're kind of the manager of the room, and we're and I don't wanna jump ahead, but what are the next? I'm gonna keep that thought to myself, and we're gonna talk about that in a few minutes. But,
Oh, sure.
why don't you talk a little bit about the CST or the scrub person in the room?
Okay. The surgical tech for the room, like you said, the OR team, um, what we've been talking about, anesthesia provider, circulator, scrub, FA, those are roles. And then who functions in that role, like you mentioned, the circulator is always an RN, and they are the unsterile part of the team. And then you have the surgical tech, and I'm not jumping ahead, but the scrubbed or the sterile people at the field are the surgeon, the surgical first assistant, and the surgical tech. Surgical tech is typically somebody who is trained. They either have a certificate or a license in certain states, and they went through a program to be a surgical tech, which means they've learned all about sterility, infection control, surgical asepsis. And we'll talk about the history of surgery in a further podcast. I'm so excited about that because October is an auspicious month for us. And yeah, I
Right.
can't wait to get to that episode. But so your surgical tech has to know pretty much what instruments we'll need for that procedure, what the surgeon's preferences are, what equipment we'll need for that procedure. And then their job is to set up and maintain the sterile field, do the surgical counts with the circulator, maintain any specimens that come out of the patient, keep them properly labeled, and as well as keep track of anything we use during that case, as well as specimens and medications that are labeled and used on the field. So typically, when we have a patient for surgery, we create a sterile field. So everything we use is sterile. Everything that touches the patient is sterile, which means it's been sterilized and there are absolutely no bacterial growth on there. So asepsis without infection, as opposed to antiseptic, which in the early days was that carbolic that they operated in. It reduced the number of bacteria, but now through the process of sterilization, everything we use at the surgical field is sterile. So it's if it's instruments that are used over and over again at the surgical field, then the hospital, their sterile processing department sterilizes instruments. The packs and equipment and drapes that we use, they come to us sterile, so they're already prepackaged and usually gamma irradiated to be sterile. So there is absolutely no bacterial growth on those at all. And that is pretty much the surgical tech and surgical tech role. Is there anything I missed when going over that, you think?
Yeah, I mean, one thing I wanna emphasize on the surgical tech role is that maintaining that sterile field is
Exactly.
so
Yep.
important, and being like, if there are students in the room or,
Mhm.
inexperienced residents coming in, if there are other people coming in the room that may not be familiar with sterile fields, it is that surgical tech's primary responsibility to keep that field
Set
sterile,
up
and that
and
is not an easy job sometimes to have your eyes in 2 places. They're trying to pay attention to what they're doing. They're also having to keep one eye open for other people in the room and how their field is doing. Is their field close to anything? So that equipment or something else, and even other staff members. We all,
yep,
joke that anesthesia comes in the room, and they are not concerned about that
right.
sterile field. They breeze by it any old way, but that's a big deal, and so,
You brought up a good
a
point too.
good
One of their roles, one of the functions of a surgical tech, and anybody's role in the operating room during a surgery is to spot breaks in sterile technique. So we want to
correct.
spot those so we can address them. If a
Mhm.
surgeon touches something that's not sterile with his gloved hand, then you want to point that out. And nobody
Yep,
should ever give you any grief for pointing out a break in sterile technique
ever.
because that's about the safety of the
No.
patient. I remember when I was a surgical tech student and I saw a surgeon contaminate his hand. I was so afraid to mention it to him because I thought I would get my head bitten off
Mhm.
about it, but I actually didn't. I told him, he's like, "Oh, okay, can I have a new glove, please?" And you never argue about sterility. If somebody raises a question about sterility, it's always when in doubt, throw it out because it's so easy to get something new
Absolutely.
because, that patient is gonna bear the burden of that break-in technique. They may catch an infection that they are not physically prepared for, so especially in
Right.
total joint surgery. I mean, asepsis is paramount in any surgery, but mostly so in total joint surgery because you don't want an infected total joint, because
No.
that patient can suffer a lost limb or everything up into including losing their life. So, asepsis is our
Right.
primary goal, and that is the primary role of the surgical tech. They are specifically trained in that.
Mhm. To the point of, really inspecting instrument trays
Hmm.
that they're lifting out of caskets and stuff, looking I've seen a couple of travelers, actually, traveler CSTs catch very small things that I wonder. I mean, I call her eagle eye. I called
Mm.
this one girl, I was like, "You have an eagle eye." I mean, she would find
Oh. Mm.
a hair in the bottom of a tray that we all know it's not sterile. If
Hmm.
there's a hair in the bottom of a tray, that tray can't be considered sterile. I mean, we all
Right.
know that. But just to the point of being that what's the word I'm looking for? That thorough,
Mhm.
and having that eye for maintaining that sterile field is
Yes.
it's so important, and I always, yeah, and you're never in trouble with me when you speak up on, when it comes to patient safety and the sterility of that field. So,
Constant vigilance.
big deal. That's a big deal as far that, you know, and I and we as first assistants, we have to it's great to know when you have a solid scrub tech there, that they're on it, that they're on it and they're watching things when you can't be watching things, and vice versa. I mean, sometimes they're busy doing something and I'm watching
Mhm.
things. Maybe I'm not busy in that moment and
Right.
I'm watching things when they can't be watching things. So we kinda have each other's back like that, and I think that's really cool how we work
Exactly.
synergistically
Yep. That's why
together in that.
sterility is everybody's responsibility because, like you said,
It
you can't
is.
be focused on everything all the time. That's why anesthesia may spot a breaking technique, the circulator may spot a breaking technique, the tech, the first assistant, even sometimes the medical student. No, most of the
Absolutely.
time they're the one doing it, but no, kidding. We
Mhm.
won't say that, but it's probably more true than not. But anybody brand new in the operating room, I mean, we always want to tell them,
Right,
hey, stay 18 inches away from anything blue or green,
right.
depending
We
on the
say
color of your
yeah,
scrubs. But yeah.
right. Well, we know everybody's hackles go up when we've got students in the room and people that know, and at one time, we were that person that didn't
Oh,
know
that's
much
true.
about it, but,
But that's why it's
uh
incumbent upon us to teach them because let's face it, the operating room is not like any other patient care area in anywhere else in the hospital. The rules are different.
right,
Everything is different. I mean, we do things that no other department does. Now, some other departments do procedures where aseptic technique is required, but I mean, surgery is where it started, and aseptic technique is our primary function and goal. So,
it is, and yeah, it is. So, I tell you what, I always appreciate a good my scrub techs. They're awesome.
what's the
They're awesome, and I
you
love
wanted to talk about the next role?
well, yeah, I mean, then we move into the first assistant. I mean, we're gonna talk about the first assistant and what role do we
Hmm.
play in the operating room. Um, and, John, I hear from more and more people as we get travelers into the operating room,
Mhm.
traveling circulators as well as techs, there are we need to research this. We need to look up, I
Okay.
don't know if there's a way to do it, how many facilities not that's the wrong way to word it, but what percentage of facilities don't utilize first assistants? Because
Right.
have you met people recently that said, "I've never worked at a facility with first assistants." I mean, it blows my mind to hear that, and I don't hear it a ton, but yet and still, I have heard it some from travelers, people from, other states. They they're not used to working with first assistants.
Yep.
And so it's always interesting to work with someone like that and be on
Mhm.
a team with someone that's not used to having a first assistant in the room and they don't know what to expect. They don't know what our role is. So just kind of jumping off into that
Exactly.
subject and what is our role?
Mhm. Well, it can be different. I mean, every state is different, even how they utilize surgical first assistance. If they use surgical first assistance, there are states like New York, New Jersey, California that don't
Mhm.
recognize surgical first assistance, but they do, however, use RNFAs. So they may be familiar with the role of first assistant, but who fills that role
Okay.
is different. So
Mhm.
it may be a nurse practitioner, it may be a PA, or it may be, and I don't mean to, to steal your thunder, but it may be an RNFA. As a matter of fact, I had traveled to one state where they were primarily RNFAs, but myself and another traveler were the first surgical assistants they had ever had there. And it was a difficult
Uh-huh.
adjustment because they didn't think we could do the same thing that the RNFA did, even though at the surgical field, it's the same. The role, the scope of practice is exactly the same. So, myself and this other gentleman, we faced it was difficult in the beginning because I would ask for something and they would tell me no. I'd be closing a wound and I'd have to fix a dog ear, so I'd ask for a knife and they're like, "Nope,
Really?
nope, I'm not gonna give that to you." I'm like, "Excuse me?" They're like, "You can't do that. Only an RNFA can do that." And I'm
Well,
like, "Well, no, that's not
oh,
true."
so some education needed to take
Exactly. So this
place.
other gentleman and I went to the
Right.
OR director, and luckily she had come from a facility that had used surgical assistants. So in just one of the morning meetings, she just sat down and explained to everybody what our role is, what our scope of practice is. And
Uh,
when it comes to the surgical field, there is nothing in that role that we can't do that a nurse practitioner can't do, an RNFA can't do. We
right.
all do the same role. Outside of that, some of the ancillary duties we can't do. Obviously, I can't order and interpret exams. I can't give medication. I can't order medication. So, whereas a
Right.
PA might be able to do that, but
Well, that's an excellent point, and in a nutshell, you're right, that the first assistant, while is our specific title
Mhm.
and our certification and
Yes.
our role as well, it can also be seen as a broad term, right? Like, the first assistant
Mhm.
in the operating room can be different credentials. So,
The first assistant is
you
the
just
role. That is the role we
it's the
play,
role.
but
And
our
so, yes, an RN a first assistant, a CSFA or a
Mhm.
CSA can fill that role. An RNFA can fill that role. A nurse practitioner, some would argue that we're not gonna get into that.
Right.
Some would argue that a nurse practitioner, is not qualified. I've heard some people argue that. We're not really gonna talk about that. We all know that surgeons have nurse practitioners that work with them,
Mhm.
that are skilled, they're educated, they're trained, and I think, yeah, we all have that experience. So we're not gonna get into that discussion today. And I know there's gonna be a listener that says, no, nurse," but
Right.
I will acknowledge that that is an argument. We're not gonna argue that on today's, but a nurse practitioner can fill the role, and of course, a
Right.
PA can fill the role. So there's surgical physician's assistant. And John is absolutely right in that in the intraoperative setting, intraoperatively, there's not anything that differentiates us.
Correct.
Would you
I
I
agree.
mean, I would agree with that,
Mhm.
and I think that's an accurate thing to say. During that surgery, there's not anything that a PA can do or an RNFA or a nurse practitioner or a first assistant can do that the other one can't do. We're interchangeable in that role. I mean, because like you mentioned, when it comes to ordering meds or prescribing
Mhm.
meds, that's outside of the operating room. That happens outside of the operating room.
Correct.
Anything that we're doing, we can inject lidocaine.
Mhm.
We're doing that under the surgeon's supervision. So, let's talk about that, John, that we are
Sure.
that's a good I'm glad I said that. That's a good
Mhm.
who are we working under as the first assistant?
Well, as a first assistant, we work
Mhm.
under the direction of the surgeon. He is directly and
Right.
indirectly responsible for us. So he doesn't
Okay.
necessarily, and this may vary from facility to facility and hospital to hospital, but he, for certain roles, for certain functions we do, he may have to directly supervise us, like whether it's closing fascia or whatever the hospital specific duties are, or injecting local, he may have to be present. A lot of times, as long as the surgeon is in the hospital, they consider that indirect supervision. So, we're allowed to function in our role and responsibilities. And each operating room has their policies and lays out what every job role is allowed to do according to their policies and procedures. We, as surgical
Correct.
first assistants, have our own scope of practice. So, there's functions that we're allowed to do, but I can't, for instance, if I'm closing a wound, I can't look up to anesthesia and say, "Give him a gram of TXA," because that is ordering a
No,
medicine that's outside my
that's right.
purview, it's outside my role and
Right.
responsibility, that's not something I would do. Now,
Correct.
brings up another point, which I've been in cases, and Kelly, I wanna hear your point of view on this as well. It applies to me more so as a traveler, because if I'm new at a facility, I haven't worked with that doctor before, and let's say whatever the procedure is, he starts it, injects local anesthetic, we perform the procedure's done, the surgeon leaves. As the first assistant, we're responsible for closing the incision, so now I'm closing the incision, and the tech looks at me and says, "Go ahead and give the rest of the local." The doctor always gives the rest of the local. I'm like, "Okay, thank you. I appreciate that." But he didn't give me that order before he left to give the local. So if you want to call him back, either call him on the phone, page him, or ask him if he wants me to give him the rest of the local, I will do that. However, I can't take it upon myself to do that unless he specifically told me before he leaves, "Hey, why don't you give her the rest of the local before you're done?" A lot of the places I've
Right.
been, the surgeon's still in the room. Maybe he's writing orders, maybe he's reviewing the chart of the next patient, and I'll just look over and I'll say, "Hey, doc, do you want me to give the rest of this local?" And then
Mhm.
he's given me a direct order to do it, and I do it, but I can't take it upon myself to give this patient local because I want to give them local. And I've said that to the staff before. I was like, he may do that on every case, but he didn't tell me that, so I can't do that. And I'll have them call, and I've had it happen where they've called him and he said, "No, I don't want them to have any more local." Plus, as we well know, there's toxic levels to all local anesthetics, and it's incumbent
Right.
upon us to know what they are. So I always keep a running total in
Correct.
my head. I always check with anesthesia before I inject any local. Does this
Absolutely.
patient have any allergies to this? What's their weight? Because all of our medications are weight based. So that's just something that
Right.
I do, but that's a good point.
Nope, and I appreciate that you brought that up because that is I feel like you handle that well and appropriately for sure. It is a difference when you're a traveler, but you're
Mhm.
right. I mean, technically If the doctor did not tell you to give the surgeon did not tell you to give more local anesthetic, you don't have any business doing it. Yeah, you don't. It gets a little more gray when you are staff at a facility and you know your surgeons, you work with them all the time, and you know they're not gonna care. In that case, so what I'm telling you, have I injected lidocaine without receiving a direct order from the surgeon? Yes, I have. It is with surgeons that I know well
Mhm.
and that I work with often. In that case, I still confer with anesthesia.
Oh, of
I
course.
say, "We've already given we gave this much at the beginning. How much do they weigh? How much more can I give?"
Mhm.
I always announce, I always make sure, and so I announce to anesthesia that I'm giving the local, and I always make sure that I read it out loud what I'm giving.
Mhm.
Just going through those safety measures. I will tell you this, though, if anyone in the room, particularly the circulator, verbalizes a problem, they have a problem with me giving more anesthetic, or they don't feel comfortable with me giving anesthetic
Mhm.
without the surgeon's order, I will stop right there and say, "That's fine.
Mhm.
I won't give any more. If you would like to call him and see if he wants the patient to have more, that's fine."
Right.
We've gotta at the end of the day, we gotta watch out for the patient, and we've gotta
Exactly.
do things the right
Mhm.
way. I mean, we just do. You can roll your eyes, you can feel
Right.
whatever way you want
Mhm.
to about it, but at the end of the day, you are exactly right. We technically can't do that without the surgeon's order. So,
Right. But I think in your situation, you may have had an order from him and not realize it because the more you work with somebody and get to know them, you have conversations with the surgeon. I do all the time. And I ask them, I'm like, hey, listen, you may not be in the room, but if I see bleeding, are you okay with me bovying or suturing or doing whatever I need
oh,
to
right.
stop that bleeding without you there?
Mhm.
And if I work with a surgeon constantly and I'll say, okay, on these cases, I see that you always inject all the local. If it's, a case where you don't inject all the local, is it okay if I inject all the local unless you tell me a reason not to? Because maybe he wants the patient to be able to have sensation when they wake up because it may give them,
Mhm.
especially with neurosurgery and back surgery, maybe they don't want them to have, a block because they want to be able to assess their neuro status when they wake up and their sensation status when they wake up. So that's why I always
That's a
ask.
good
But
point.
it's a slightly
Yep.
different when you work somewhere and you work intimately with that surgeon and you get to know them.
Mhm.
You do get that order in a roundabout way, but I always ask, I always double check, and I have no
Well, you
problem.
gotta cover yourself, especially on a travel assignment. You have to cover yourself as
Yeah,
well.
cover
So,
myself,
sounds like
but
you're doing
ultimately it's protecting the patient because I think,
absolutely.
if maybe the surgeon has another plan for them afterwards, or maybe they've had a
Mhm.
block or they're getting a block, and now if I've given
Mhm.
them all of the, Marking that they can get, now they can't have a block because they've already had, the maximum dose they can
Excellent
have.
point.
So I
Yep.
always double
It's a good
check, and I
point,
don't
John.
feel bad asking at all or having the nurse ask because, I always think about it, and I always think about it as how would I justify that if somebody came to me and said, "Hey, why did you give the rest of the local?" "Oh, well, so and so told me that you always do it." Well, I don't always do
Right.
it, so so I just don't wanna be in
Yeah.
that
And are they
situation. I don't want to cause the patient any harm because let's face it, they can always give them more pain medicine. They can always do a block
That's true.
after the fact, but
Mhm.
yeah, I can't give
Yeah.
medicine like local anesthetic without an order, so I always make sure I have an order.
Right, and knowing you brought up a great point too about the block after. I mean, more and more I'm seeing tap blocks being given in the PACU
Okay.
versus, uh, prior to surgery or yeah, on the operating table prior to surgery. So, considering that taking that into consideration is an important thing too.
Mhm.
What other modalities are we gonna use to control their pain?
Right.
And are they getting those blocks? And will that affect, it's easy to say, well, 10 cc's of this local cocktail, lidocaine, Marcaine, whatever it is, or cocktail is not gonna affect that. Well, you can't assume that.
Mhm.
You have to check and double check. And at the end of the day, don't do it if you didn't get a direct order to do it. So that's a very good point you brought up.
I think
We're just
where else do you find in the first assistant role where you can have, when you're talking about team dynamics, where you can have conflict maybe with other members of the surgical team? I find it as a traveler, every hospital is different and they do things differently. Certain hospitals, only nurses can insert Foleys. Certain hospitals,
yep.
only nurses can position the patients. And so I always try and fall within that role and I ask, hey, listen, I'm used to doing it this way, but how do you guys do it? I've gone to position a patient and have had nurses push me out of the way because they tell me that they're
Mhm.
going to position the patient. And I'm like, Okay. And then I'll just stand by and help wherever I can and also make sure that everything is the patient's positioned correctly, everything's padded well, and there's no pressure points on the patient. The axillary roll is in the right place, or when they're placed in a lateral position, or if they're put on the HANA table or something that the HANA table set up correctly. So
So, gosh, there's so many points here to talk about. There's just so
mhm,
many, and it can be challenging as we've both, talked about previously and acknowledged. It can be challenging when working with a team that maybe is not used to working with a first assistant, and circulators can be some of the most difficult, challenging, I should say, because when there's not a first assistant in the room and they're not used to having that role in the room, they are having to take on a lot of responsibility. It's a lot. I mean, so a veteran circulator will be accustomed to doing so much, and you have to get into a routine of doing that. I mean, you and I both have our routines. I know you do, if I do, we have our routines of checking and positioning and checking to make sure everything's done, all the safety, you know, thing aspects are done. So it can be challenging those times when you have, you're kind of just treated and it happens a lot in traveling because they don't know you when you come in, they don't know
right.
your experience, they don't know. So it's hard to deal with different personality types and I've had the experience in traveling where I somebody just completely I just felt like, "Oh my goodness, they're not." How rude.
Mhm. Yeah, that can definitely be the
Like,
case.
just didn't hit it off with them right away and then ended up working great with them,
Mhm.
after you just get past that. You just gotta come to an understanding.
Right.
So, eventually, you have to have a conversations with people like, "Look, hey, we're on the same
Mhm.
page. Like, we both want the patient to be safe. We want this, procedure to be carried out safely and effectively, and I'm here to help you." So, like you just mentioned, I think on the outset when that happens, we need to step away, take a step back. I feel like you just said that's what you do. You take a step back and say, "Okay, if you need me, I'm right here."
Mhm.
And at the same time, John, you're using your expert eyes to make sure that everything's right. And you have to feel comfortable speaking up and about any concerns that you have,
Mhm.
right?
I agree, and
So
at the end of the day, we're all people and we all have our own issues that we deal with, and, I always approach it with the nurse or whomever in the room is that, "Listen, we're all here for the same reason, that's for this patient and to make sure that this operation is done in a safe manner and that we are able to complete the surgery to the benefit of the patient." Now that being said, if I see something that I don't think is right, I will most likely speak up about it, but I think a lot of it in facilities that aren't used to using first assistants or where first assistants are new to the facility, some of it is education because a circulating nurse will take on more responsibility than what they actually have. I've had nurses say to me, "Well, you can't do that because my license is on the line." And I'm like, your license doesn't matter here. I work under the surgeon, not under you. You can't do what I do because you're not trained and certified to do it. I can't do what you do because I don't have a nursing license and that's not my responsibility. So I always
right,
try and tell them that way. If it gets more heated, then I would just leave it right there, and I try not to let it get heated, especially in the room at the time, and I'll take it out elsewhere, but I find a lot of the issues in my experience have come to where it's around positioning patients, and I will eventually just say to them, "Hey, listen, if you see anything that I should be doing that I'm not doing, please tell me because I don't know exactly what you guys want me to do here. Or if there's something I'm doing that you don't want me to do, please tell me so I can stop that. But I want to help as much as I can. So just please let me know." And a lot of times, let's face it, you might have a nurse that is a 5 foot 80-pound Filipino nurse or just a 5 foot petite nurse that's trying to position a 300-pound patient. I'll say, "Hey, would you want me to get up there and flip the patient up there? Because I'm a little bit of a bigger guy. I'm 5'10".
right.
I just think they're short. I'm taller. It just might be easier. I'll just ask them out of
Mhm.
courtesy, just because of chivalry. Let me help but at the end of
Right.
the day, if they don't want me to, then there's really not much I can do about it. I'm not going to hip check them out of the way and grab the patient. But at the end
Right.
of the
I
day, I'll
mean
make sure I'm close, so if I can help if need be at the last second, or a lot of times I've had a surgeon step in and say, "Hey, John, why don't you get up there and grab that part and let Mary go down to the
uh-huh.
foot," or whatever the is go down to the foot
Right.
or whatever. But
Right.
yeah, ultimately, we were responsible to keep that patient safe, but I believe at the end of the day and legally when it comes to positioning patients, it's anesthesia's responsibility.
It is, in fact. It is anesthesia's, and I will if I feel like I'm struggling with a nurse or another team member that's helping with patient positioning, I will absolutely, throw it back to anesthesia and make sure that they're happy with the positioning. Um, we all know that there's more than one way there's more than one right way to do things many times. Sometimes there's a best way. And so really it's discerning, in the specific situation, what's best for the patient again. And I have to go through that in my mind. I have to say, well, does it matter, Kelly, that they want to do it their way and they don't want to do it your
Mhm.
way? As long as the patient's safe, that's what, is important. If I feel like there's a better way to do something or that the patient's not going to be safe, I do throw it back to anesthesia. A lot of people don't know that if a patient is injured, and it is a result of it's a positioning injury, that falls on anesthesia ultimately. They're responsible for patient positioning. Again, throwing it back to anesthesia and saying, "Hey, are you happy with this? Are you happy with the way this hand looks? Are you happy with the way this arm is looking? Are you happy with this axe roll placement?" Anything like that, I wanna toss it back to them instead of just, if somebody's being argumentative or wanting to be challenging or difficult, that's a one way to diffuse that as well. But just I hear you saying what I hear you saying is just
Mhm.
having humility and being teachable. Maybe somebody does know a better way to do it. I've gotten to where I ask, "Why do you do it that way? I've never seen it done that way. Why do you do it that way?" Not as a challenge, and not maybe in the moment, but why do you like to tuck the arm like that? Or why do you like to put the draw sheet like that? I might learn something,
Yeah, and
and that's how I have learned things.
exactly, and I've been in that situation, and I was just there just recently on my last assignment. I ask myself at the end of the day, "Is this gonna result in patient harm?" That's all that matters, and if it's not, then that's fine, I can let it go, and I would always
Mhm.
be that way. I used to be very vocal and say, this is wrong, you're doing it wrong," but we all grow up and we all mature and become
Right.
more humble, and that's where I keep
Yeah.
growing towards that. But, for instance, it was a case where we were doing a radial head fracture on a patient, and typically, I've always done those with the patient supine and the arm out on an arm board, typically,
Yeah.
right? Well, the staff in the room is arguing with me that we're gonna do it lateral with the patient and the arm on called a paint roller or a device that holds the arm in position while you do that. And I
Uh-huh.
said, "Okay." I said, "But typically, I haven't seen it done that way. Like, olecranon fractures, distal humerus fractures, yes, I've seen them do them in that position, but radial head
Right.
fractures, I've seen them done always supine. But hey, I don't mind, we can do it that way. If that's the way he does it, then it may be a way that I haven't seen before, but maybe he does it that
Right.
way, so let's do it that way." So I went and put everything on the bed that required, and then as soon as the doctor came in the room, they asked him, "Are we going lateral?" He's, "No, this is supine. I always do these supine." And, you know, in my head, I said, "Yes, that's right." But I didn't go, "That's right," and look at everybody in the room and point to them. But no, I
But
just
you want to
started
so
taking right. I just started
bad.
taking everything off of the bed, and I was like, "Okay," But at the same time, my ego gets involved because I don't want the surgeon to think I'm an idiot and I don't know how to
No,
position this
I
patient.
know.
And in the past, I would have said, "Well, the team wanted it positioned this way. I
Huh?
wanted to do it the correct way," but well, then that doesn't make any friends and it creates a very hostile work environment for
Yeah.
me.
Listen,
So,
the
yeah,
struggle is real. It
yes,
is so
but I'd
real,
like to
and I
think I've grown up a little bit and I don't try not to do
right.
that anymore. I still walk into
But
a
we
buzzsaw every once in a while, but
but we want the listener to know that we really wanted to keep this conversation as real as we can because
it
we've been
happens.
there. Like,
It
when you're
happens.
with a team and listen, y'all, I don't know
Right.
everything. I
And I
do
don't
not.
either.
I do not know. I mean, 11 years of doing this, I don't necessarily know the best
Right.
way of doing things. I like to think that I'm a person that admits and says, "Listen, I am not an expert here. I don't do a lot of
Mhm.
these. I don't know all of the positioning ins and outs of certain procedures, and I will, but there are some things and there are a lot of things that I do know, just like
Mhm.
you knew this positioning, the typical positioning
Right.
when you're going to fix a radial head.
Mhm.
It's typical. It can be one of the hardest things for me and my personality, the way that
Mhm.
I am, to encounter a team where you just feel like you are not being listened to.
Right. Right.
You know? Because that's what it feels like. It feels like you're not being listened to, And sometimes I've thought, "Am I going crazy? Am I, like, thinking about this wrong? Am I, like, thinking of another procedure that" and you know you're not. But what do you do?
Right.
When you've got if you've got more than one team member, if you've got the circulator and the scrub both saying and especially this goes for if you're in a travel
Yeah, oh,
position.
exactly, yes.
If you're in a facility that's not your home facility,
Mhm,
you're not core staff. It's especially difficult. The only thing to do is just to say, "Okay, exactly what you
mhm.
did." It's really the only thing to do, and as badly as you want to say, "I told you!
Exactly. "See?"
I
But
told you
yep.
it was" and I'm telling you, I probably have let that come out of my mouth in one form or another,
Mhm,
whether it needed to or whether it was the right thing to do or not, I can't it wasn't. It wasn't. But it feels
mhm,
so I feel so
yep,
frustrated in those times, and we do, and you're going to have times like that as a first
yep.
assistant, you're going to.
But I guarantee you, if I'd
Um,
have said, "Listen, I've been doing this for 25 years. Every single one I've done supine," the surgeon would have come in and said, "No, I always do these in a lateral position." And I would have looked like an idiot. I would have
yes.
felt like an idiot. And
I've done that
at the
too,
end of the
and I
day
have done that. I have spoken up and
mhm.
put my foot down
Oh,
and said, "We're doing it like this," and then they come in and like I'm like, "Oh,
yep,
I have never seen it done like that before." So, it
right.
only takes one time.
But at the end
It
of the
takes one
day
time of that happening,
right, exactly.
and you're like,
This
"Okay."
is the staff that works with him all the time. I'm the new guy, I'm the traveler, so I don't wanna disrespect the staff. I want them to feel that they're being listened to, and I'm not
Yep.
disregarding them, and I'm being arrogant and saying,
Yes.
"I know what's best." I'm like, maybe they do know. They work with the surgeon all the time.
Yeah,
I've worked with him, what, 6
that's
times
right.
before this, and I haven't done a
And
radial
of
head with
course,
him
you have
yet,
to consider
so
that.
right, exactly. So
Mhm.
I've learned to just, "Okay, whatever, because it's too easy to change it. It's too easy to change it. I just
It is too
off the
easy to
beanbag
change
and the
it.
paint roller, no problem. Now we're doing it supine." But I'll
Yeah,
leave
and
the
being a
arm board in the
jerk
room. I
and
won't
getting
take it out of the
mad.
room. I'll leave the arm
Right.
board in the room. But yeah,
Yes, yes.
exactly. But
Do things kinda subversively, right, and say, "I'm just gonna get ready in case I'm right. I'm gonna keep this in here."
and
Exactly.
I'll tell them,
That's
I'll say,
exactly
"Okay,
how you handle
all right,
that.
but I'm just gonna leave the hand table in here just in case he wants to do it supine. That way I don't have to
Yes,
run
and
out of the
that's
room and get it." And they're like,
uh-huh,
"Okay."
and that's what you just call just rising above. Just rise above it and just at the end of the day, we want to have this positioning right for the surgeon. We don't wanna waste a lot of time. We wanna move it along, and we're not gonna point fingers and blame and fuss about it. You know what? You can do that. You can have a conversation with somebody later on in the hallway.
Mhm.
If you have a problem with how you were treated or how you were spoken to, you can have a conversation with someone later. There's nothing wrong with that, and you should because I'm not we all say
Right.
that the OR is one of the toughest places to work. It's one of the toughest environments to work, and there are a
It
lot of
is.
strong personalities, and you should never feel like you're being stepped on
Right.
or that you're being minimized
Or belittled,
or, bullied or belittled or
insulted. Right.
condescended to. You should be able to have adult conversations with people out but the time and place for that is not
Not
in the
in the
operating room
operating
with the
room.
patient on the
Exactly.
table, okay? That's what we need to take away from this discussion right here, and
Exactly.
Kelly has had to learn that. Kelly, I have had to tell myself
Mhm.
that. I know you
I've had
have
to learn it
too.
too, exactly. It's
Mhm.
not an easy thing to learn. Being humbled and learning that is not an easy thing, but it's essential, and I think it makes you a better tech, better assistant, better nurse, better
Uh-huh.
person, but at the
Right.
same time, the ego doesn't like to be leveled like that and know that
It
it's not in
doesn't.
charge. But at the end of the day, we're all here for the patient, and if it makes better
Right.
patient care, then fine. Nobody cares what I think about it. They really
Right.
don't. As long as the patient gets the correct care, the right surgery at the right time for the right operation, and it makes their life better, then hey, I'm all
Mhm.
for it, and I can always learn
Another
something new.
Yeah, and another, scenario along the same lines is when you're working with inexperienced. Maybe you're working with an inexperienced team.
Yes.
I should say a less experienced team than yourself, right?
Mhm.
So how many times, John I'm just gonna bring this up and say it. You can edit it out if you don't like it.
Okay.
How many times have you been working with a circulator
Mhm.
and a scrub, one or the other or both, and you felt like they had been in this, working that they were experienced, that they'd been doing this for a while
Mhm.
and you were with an experienced team. How many times have you been doing, in a room with a right hemicolectomy,
Mhm.
okay,
Oh.
and they put stirrups on the bed?
Oh, yeah.
How
Yep.
many times that happened to you? Has it happened as many times to you as it has to me? And call me impatient. I have my personality flaws.
Mhm.
We all do. But when I tell you how I have to just keep myself from rolling my eyes and being like, "Guys, what is happening?
Mhm.
Why do we have stirrups on the bed when we're doing a right hemicolectomy?" John, it's so important. Again, I'm gonna bring it back to humility,
Mhm.
to just bring it back into humility and count it as an educational opportunity that you can educate your staff. And that segues us
Mhm.
into a role of an experienced first assistant. We can be educators on the job.
Right. I agree.
We can be educators.
Yep.
And, how would you handle that? How do you handle that when they say, "Oh," and, they'll look at you with this deer in headlights look and say, "Oh, we don't need stirrups." Do you just say, "No, we don't. Take them off the bed." Or do you use that as an opportunity? What do you do?
Well, in that situation, what I will do is I'll say, "Well, what's on the preference card?" And I'll go look at the preference card,
Okay.
and that's not always a savior
No.
because it could be wrong. It could be a merged card from another case, but typically,
Yep.
it's only when you're working on the left side of the colon and the rectum that you need to have stirrups. But at the same time, people are people, and it just happened to me the other day. I was doing a right hemicolectomy, and I know we don't need stirrups for that. But I said, "Hey, do you want me to get the stirrups?" Because I was new at that place. I wanted him to think I'm paying attention to detail. I'm thinking ahead. I want to
Mhm.
get everything ready for the next case. And then I realized, and then the first assistant I'm working with, she goes, "This is a right hemicolectomy." And I'm like,
You're like,
"Yeah. Oh,
"Okay."
no, I know, but where do you
Yeah.
keep them in case I need to go get them?" Is really what I was asking, but I don't think he bought it. But,
Right.
right. And in that case, I it's different, like you said, as a traveler. I'll pick a hill to die on if I think it's important to the patient, but something
Eh
like that, I'm like,
right.
"Fine, whatever," because it's too easy to take them off.
It is.
And if they're wrong and the surgeon comes in the room and makes a statement about it, then I don't need to add to their feeling of, "Oh, they're" I don't need to belittle them on top of them already realizing they made a mistake.
Absolutely. No, 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 no.
I usually won't say anything. I'll ask about the preference card. Is it on the card? I'll say, "This is a right hemicolectomy. Typically, we don't use it, but is he doing
Mhm.
something I don't know about? Is there
Mhm.
another procedure that's not on the card or whatever?" But if they insist on putting it on there anyways, then and before the patient comes in the room, you can only put 1 stirrup on anyways. You can't put them both on. So
Correct.
a lot of times the
That's right.
surgeon's usually there by that time, but that brings up a good point. If it ever comes to that where I don't think it's being positioned correctly, I will go find the surgeon in the lounge and ask him. If I think it's that big of a deal, I
Absolutely.
will go ask him, and then I'll come
Mhm.
back and say, "Hey, I just checked with him, and he says he's not gonna need need them." So
And honestly, if you try to do that so ideally, as the first assistant in the room, ideally, you wanna get with that surgeon ahead of
mhm,
time. And that's in an ideal perfect world. I know it's not possible all the time, it's not. But ideally, as the first assistant, you want to confer with the surgeon and get his surgical plan. Talk to him about his surgical plan. Say, "Hey, what are we planning on doing in this case?" That's perfectly acceptable for you to do. If you're a new first assistant and you're not real comfortable doing that, listen, there aren't a lot of surgeons that aren't going to appreciate you asking that question and getting the basics from him. That's when he's gonna be able to say, "Yes, I wanna go lithotomy for this. Hands, arms tucked, arms out." Whatever the position is, we're gonna go left lateral, modified lateral, all the different I could go through all the different positions, but that's his opportunity to tell you, and now he has the confidence to know, "Oh, I've told somebody, one of my team members, what surgical approach we're taking, what position we need to be in, and you can just kinda get a quick rundown. It doesn't take 2 minutes
nope,
for him to say, "Yep, this is the surgical plan. This is what we're gonna do." So
and to what's the word I'm looking for? To, avoid any of those issues, what you can do is
yeah.
what I try to do as we're finishing one surgical procedure. And let's say I know the
Mhm.
next one is a robotic hemicolectomy and we're winding down and it's a time that we can engage in discussion. We're starting to close, but the surgeon's still there. I'll say, "Hey, about your next case, is there anything you want special for that case? Or how do you want to do
Perfect.
the
Mhm.
positioning? You want typical supine or do you want this, that?" So that way he can say it then, the whole team can hear it. And
Yes.
then I don't put myself in that situation. I try to do that when it's possible. If
Mhm.
we're doing, let's say, an anterior hip and the next case is a 500-pound hip, he might not do that hip the same way. He might do it in a
Exactly.
posterior, doing the patient lateral and doing a posterior approach to the hip rather than in
Mhm.
a direct anterior approach. So
Correct.
rather to circumvent any of those issues, I'll just ask them ahead of time. And a lot of times the teams are
Mhm.
proactive and they'll do that. A good experienced circulating nurse or a good experienced tech will do that. Hey, your
Yeah,
next
and
case.
I don't care who speaks up first and says it.
Right,
As long
exactly.
if
As
we're all
long we're all
hearing
on the
it, it's
same page that
fantastic.
way.
Mhm.
Like, is there one thing I always like to ask, is there anything I learned that early on as a tech. Is there anything special you want? because a hernia repair is a
Uh-huh.
hernia repair, but every patient is different. Every hernia is different, and maybe they wanna do
Absolutely.
something excuse me, wanna do something different. So I was like, "Is there
Mhm.
anything special?"
Yeah.
"Oh, yes, I wanna
They
use
might
the
be trying a different
Aquamanus on this
mesh or
patient." Right.
something.
Maybe the
Mhm.
patient's a Jehovah's Witness, and they don't want a lot of bleeding, and they have a piece
Correct.
of equipment called the Aquamantis, which is, not like a bipolar, it uses intercalation to stop the bleeding, but, maybe they wanna use something
Right.
like that, or maybe they want a cell saver,
Mhm.
maybe they want this or they want that. So I always
Correct.
just
So many
ask, anything
things.
special you want for certain and
Mhm.
you'll learn this as your career advances and the more experienced people you work with and get switched on teams will be proactive, and I always try to be proactive as an assistant.
Yes. But that's, and it's one thing I really love about our job is that when I get to educate, especially new younger nurses,
Mhm.
circulators, younger techs in the operating room, maybe that haven't been doing it for very long, and I can educate them and help them to anticipate the same way. If I can educate the nurse, listen, if we're doing a right-sided, if you think about anatomy, if we're doing a right-sided colon or transverse colon, we're not gonna be reanastomosing anything down below, so
Mhm.
there's no, reason to go through the rectum, therefore, we don't need to have I might just tell them something
Mhm.
like that, just explain to them that we don't need lithotomy, so we can be in supine position.
Right.
Or anything that we're doing as far as, like a breast lumpectomy, if we're doing a sentinel node, like if we're doing an axillary dissection,
Mhm.
sometimes we do need to prep out the hand. Some surgeons want the hand prepped
Every time.
in on those every time. Some surgeons want it done selectively if they're doing the axillary dissection, we want the hand. Well, a new nurse might ask me, "Why does he do it sometimes and not others?"
Mhm.
And so you can educate them, well, because they need to kinda move that arm around
Mhm.
to get into the spaces that they need to get, and if it's sterile, makes it much easier to do that. So just kind of educating your team is an interesting, and necessary aspect of our job as well.
Mhm.
It's gonna go both ways. I mean, I've had people educate I still have people educate me about things that I just
Yes.
don't know because you're never gonna know it
Yep.
all. You're never gonna know it all, and it's one of the best things about this career, I would
Exactly.
say,
And I think you've
is
said
how
it
things
I think you said it before, at the end of the day, it comes to reading the room. I read something a long time ago that says that's what
Right,
it is. I'd rather remain silent and be thought a fool than open my mouth and remove all doubt because maybe I don't
yeah,
know everything and they're gonna do it this way. And I saved myself a lot
right,
of grief. And at the end of the day, too,
right,
you may know you're right, but just keep your mouth shut because
yeah,
it's reading the room. Maybe that person, other people in that role, other different roles, they don't take advice very well, or they've been doing it
right,
longer than Moses and they think they know everything, and then you're just gonna create
mhm,
conflict. So, do I really wanna get into that?
right,
I'll just keep my mouth shut. I know, and
yes,
I need to know let everybody else know that I know it. No, I don't, so
no,
I'm just gonna keep my mouth shut, and then it'll play out the way it's supposed to play out. As long as there's no direct harm to the
mhm,
patient from it, I'm not gonna say anything.
right,
And I'm not
right,
gonna deny another person their chance to learn something, yeah, and
yeah,
their chance to be, a fool. Everybody should have that
correct.
right.
That's
I've
right, every
plenty of
it's
times
just
in my life,
yeah,
so
some hey, those are the best learning experiences when you're humbled and you're
yes, those are the
humiliated,
ones that
sometimes
stick
that's the
with you.
best.
Yeah, exactly.
I try not to make those mistakes twice,
Oh, yeah.
not do that again.
Mm,
But our roles and responsibility as a first assistant is broad and wide. I mean,
yes.
there are so many variations in our role depending on the facility you're in,
Mhm.
depending on the surgeons that you're working with and your team. I mean, you just kind of you really do have to have the gift of discernment and reading the
Yes.
room and also knowing what the expectation is.
Yes.
I mean, from facility to facility, that's going to differ.
Yes.
I mean, we could and, that we're gonna save that for another episode, but traveling, we could talk about that, how you just have to go in, just kinda figure out what the expectation is
Mhm.
for the role of first assistant. But guys, this it's really broad and it's wide, and you can do a lot, a lot, a lot, or have a very narrow scope depending on what facility you're
Oh,
in.
yeah.
Um,
And it changes along with specialties too, but we have
it
all that stuff
absolutely
coming
does.
up in other episodes.
Good
I mean,
point.
yeah, we
Mhm.
can
Yeah. To round it out, I
Mhm.
like to, John, after I've closed the patient and we've applied our dressing,
Mhm.
I do definitely, as the first assistant, I take it upon myself it's to stay scrubbed in. Somebody else will bring the bed in that we're gonna transfer the patient onto. I do stand there and assist. I'm ready to assist anesthesia with
Mhm.
extubation. So I don't know if you do that, but I tend to practice that way and just kinda stand there with the patient, making sure that they're safe as they're waking up. A lot of people wake up differently, we know this.
Mhm.
and wanna make sure they don't hurt themselves as they're waking up, getting extubated, that they're extubated safely, they don't anesthesia provider doesn't need any assistance.
Mhm.
Um, and after we get them transferred over, I've worked at facilities where it was the FA's responsibility to roll out of the room with anesthesia and roll to the PACU with anesthesia. I've worked at facilities where the RN circulator rolls out with anesthesia to the PACU. I like to pretty much make sure that that patient gets safely to the PACU. Most of the time, I take it for granted if they're fine when they're extubated and they're fine when they're leaving the room, that they're gonna make it to the PACU fine. If I have a specific concern about the wound that I just closed, if they were bleeding a lot, or if it's a case where I'm worried like a carotid endarterectomy, maybe I'm really wanting to evaluate that hematoma, and of course, evaluate the patient's neurological status. I've got those extra little things to do after a certain case. I will follow to PACU and kind of
Mhm.
um, listen to that report that's given and kinda do some extra things there. But how do you do that?
Yep.
How do you finish up your case?
Typically, it's facility specific. It's a little different for me as a
Mhm.
traveler, like you said. At the beginning of the surgery, before positioning while the patient's going to sleep, I may stand there and be ready to assist anesthesia with intubation. I believe you brought that up earlier. But sometimes the nurse likes to do it. So if the nurse steps
Right.
up there, then I'll move out of the way. Or maybe it's a nurse anesthetist and the anesthesiologist is there during induction. So the anesthesiologist will come to the right side of the patient and be ready to assist with intubation. If that's the
Mhm.
case, then I kinda move back and I get ready to maybe go get the glide scope if they need that, if it's a
Right.
difficult intubation. And then
I'm glad that you brought that up. I'm glad that you said that. I'm gonna interrupt you just for a
no, go ahead.
second because that's when you are kind of I'm just gonna say pushed back for lack of a better way to say it, but when you're kind of pushed back because there's other personnel that are taking care of those responsibilities,
Mhm.
there's always something to do.
Exactly, yep.
Right? So as the first assistant, be looking around, be looking
Mhm.
like if it's nothing but making sure the SCDs are on and running,
Right,
making sure that the patient's safety strap is on and intact, asking the scrub tech, "Do you have everything? Do you need anything? Do you need me to grab you anything while I'm not scrubbed in?" I sometimes will pull the prep stick over and get it ready, make sure everything's ready.
right.
So I'm glad you brought that up because there's always something to do. And obviously, if they think they're going to need the glide scope, that's going to be your priority. You're still helping anesthesia.
Exactly. But then that brings up another good point is maybe the circulator you're working with is something that is a person that has to do everything themselves so they know that it gets done. Some nurses are happy to relegate certain responsibilities to you. "Oh, you wanna put the Foley in? You wanna put this on?
Mhm.
Fine, do it. That makes my job easier. I can focus on doing the counts. I can focus on doing the charting." But some nurses, for their own sense of well-being, safety, or just their OCD, they have to do it all
Right.
themselves. So I'm like, "Oh, okay,
Yeah,
fine." Then, like you said,
that's
I'll get
fine.
out of the
Mhm.
way. And then when it comes to the end of the surgery, when it comes time to wake the patient up, as we all know, the tenuous time for the patient is when they fall asleep and when they're coming out of
Correct.
anesthesia. So that's when they're most
Mhm.
excitable. So I usually make sure that the room is quiet. I try not to talk. But I'm
Right. Very
human.
important
So
point.
when
Yep.
anesthesia tells me to shut up, I shut up. Some
Mhm.
people are more tactful at saying it like that, like, "Hey, guys, we're going to sleep. Can you keep it down?" Or and
Yep.
same thing when they're waking up, if there's music playing that we've been listening to, if I still scrubbed at the field, I ask somebody to turn the music down. If I'm not
Correct.
scrubbed, I'll walk over and turn it down. And then I'm
Mhm.
standing there right by ready to help anesthesia because that is the most difficult time, the most stressful time for anesthesia is a lot can go wrong during induction and during extubation. So the patient can have a laryngospasm. So I want to make sure that I'm paying attention to things, the patient's color. I'm looking at the monitor to make sure that their O2 sat is good, that they're not laboring too much. I'm listening to hear if I hear a stridor. And this is usually the role and responsibility of the anesthetist. I'm not trying to take over their role, but I'm just another pair of
No.
eyes and I'm trying to be vigilant. So
Absolutely.
if I need to break and run and get the glide scope really quickly or bag the patient for anesthesia while they draw up their succinyl choline so they can
Correct.
reintubate or hold the mask, maybe it's a difficult airway and I need to assist anesthesia with positioning the mask on the face. I just make sure I'm there. And I'll
Point.
ask them,
That's
"Do
an
you want me to
excellent point,
help
and
or what?" And some are like, "No, I got it." So then I'll just stand by.
listen, if that listener if we have somebody listening that's maybe new, you're going into this and you're new, everything John just said is so pertinent. It is so important. And it is our responsibility. You need to know how to assist anesthesia. You need to know things to look for. And and I'm glad you brought that up, John. During intubation and extubation, the entire room should be focused on the patient.
Mhm.
yes, if there are providers there that, um, that's their primary role, yes, you're just an extra hand. You're an extra set of eyes. You speak up if you see anything that concerns you, and you're there ready to lend that hand and know what your role is and how to do that. It's a very important point, and if it just is a matter of you just stepping back, I stand there with my hands folded in front of me. I might stand to the patient's side, maybe kinda down by their feet, and just watch and wait, but your focus is on that patient, and we should keep I'm gonna reiterate that. We should keep conversation to a very minimum and no music, certainly no loud, boisterous conversations at that time as well, because a lot of new people just don't know that, and so we're telling you that that is the expectation, that those are 2 very, very critical times in that room is during intubation and extubation.
Yeah, I think that's pretty
Yep.
comprehensive. It's been a long, podcast. We've
Yeah,
gone over an
I think
hour
we
with this
covered
one.
a lot of good things, yeah.
I think it's good. Yeah, we definitely covered a lot of things, but it's also in my mind, creating future things we can talk about, which is too.
Yeah.
So,
Yes, it is,
um,
so it's always something good,
and we're
yeah.
always open to take suggestions. And if there's something that you want us to talk about or research or find out about it for you, just put it in the
Yeah, please,
comments.
we absolutely, I was gonna say,
Mhm.
please comment, yeah,
Or you can send us
please
an
comment.
email at the surgical assistant podcast at gmail.com. We'll put that in the description too. So,
Yeah, yeah, perfect. Alright, John, well, that'll wrap it up for today. We talked about the operating room
mhm.
team and where the FA fits in and discuss some challenges that we encounter, and, yeah, I just wanna say again that we encourage comments and questions if you have any.
I agree. Um, I think Yes, I think that was good. I think, we'll have to revisit this in another podcast because it's important, and there's
Yeah.
more stuff we can add, but I think
Yeah.
that's great.
I'm sure we missed some things, yeah, but
Yeah.
we appreciate you listening as usual, guys. We appreciate that you found us and hope that you find more interesting episodes to listen to.
Yes, and let us know. I mean, like we said, this episode ran over longer than our previous ones has. Let us know if you like the longer format or if you like a shorter format. Just let us know, leave a comment, and let us know. But, thank you for joining us, and we look forward to seeing you on the next one.
Thanks for listening today. We invite you to like and subscribe to this channel and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast or email us at the Surgical Assistant Podcast at gmail.com. Until next time. Content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient specific information is shared, and all HIPAA guidelines will be adhered to.